So our first speaker of this session is Tamsin Fletcher-Salt, who's a lead diabetes specialist nurse and has been so since 2014. And she completed her diabetes MSc in 2023, and Tamsin lives with type 1 diabetes and has set up an online support group for people in her local area. And she's won 2 QIC awards in 2021 for her work within Diabetes 101 Twitter team. Thank you, Tamsin.
Thank you. Okay, so yeah, my name's Tamsin Fletcher-Salt, as I've been introduced, and I'm part of the Diabetes Specialist Nurse Forum UK, and I'm just going to give you a bit of a brief overview of where we've been since we were here this time 12 months ago, and any changes that have happened. And if you work in diabetes, there has been some exciting changes, so but also we'll talk a little bit about some programs that have been introduced. These are my disclosures. This is just quite a nice sort of slide. Obviously, it's a little bit more than 75 years now, but we have moved on a little bit from, urine testing and test tubes and tablets and things like that. If anybody has been in diabetes for a very long time, they'll remember those. And, sterilising needles and reusing needles when it came to insulin injections. And, this year, we're in the exciting times of being able to offer hybrid closed-loop technology, which both excites me and slightly terrifies me in the sense of the numbers that I have to get on in my local area, and I'm sure other DSN teams are in this similar boat about how you're going to manage that rollout over the next few years. But also we've had some changes in type 2 diabetes as well, with the fact that for the past 12 plus-ish months, we have really struggled, obviously, with access to GLP-1s. And this year, we have a new medication available to us, a GLP-1 GIP Mounjaro. And again, if you work in diabetes, if you have been using this, you're probably seeing, hopefully, the same results that I am, and that it's spectacularly amazing at improving people's diabetes management. And also, we're starting to see the early sort of weight loss side of things as well. So, hopefully 2024 is going to be a slightly happier year than 2023 was, when we were sort of told that we had no access to anything, including GLP-1s, but also insulin seemed to be another thing that we didn't have much access to. So, positive vibes for 2024, 2025, hopefully. If everybody knows that, unfortunately, the number of people living with diabetes is increasing, and we still have the terminology of the missing millions, and there's still people out there living with diabetes that aren't yet aware of it. And I think, as our previous, speakers have said, people very often live with diabetes, even knowingly living with diabetes, and just like, I feel okay, I don't feel unwell, doesn't matter, if their blood sugars are, in the high teens and 20s, that they're still getting up, going to work, and they don't feel unwell. So, and there's lots of people out there that, don't have that diagnosis yet, and are going out and about and living life, not realising that they have diabetes. So it's just really, that these people will be, coming into our services at some point. And unfortunately, the potential is they, they may have had diabetes for, a number of years without realising it. So what's coming, as we said, a hybrid closed loop. The UK is being watched in a sense, because, England, unfortunately, it's not quite yet out into Scotland and Wales and Northern Ireland, but England is being watched as to how this is going to impact people living with type 1 diabetes. There's nothing else, really in the world like what NHS England are trying to offer to people with type 1 diabetes. And it is a really, really, exciting time. I think we've probably all in diabetes been going through those clinics over the last few years where people have said, can I have an insulin pump? And we've had to say, no, sorry, you can't have an insulin pump. You know, you don't meet the criteria. Or you say, oh, well, we'll try for funding, and maybe you don't get the funding from your ICB. So now, you know, I'm kind of handing them out like sweets at the moment. If I see somebody in my clinic, I'm like, oh, have you thought about an insulin pump? And I go through it with them, and, you know, and I go for funding, and, you know, if you could see my office, it is piled up to the ceiling nearly with pumps that I arrive every single day, and I'm preparing, you know, getting people on insulin pumps. So, you know, the immense benefit of putting somebody on a hybrid closed loop, not only to their diabetes management, but to their quality of life. You know, I have type 1 diabetes. I've had it since 1978, so I've literally had it, you know, almost all of my life. And I've been on a hybrid closed loop for around about 2 years, and I can honestly say that I don't think about my diabetes. And prior to that, it was a constant thing. I don't have to think about it, you know, every hour of every day like I used to do. I don't have to be worried that I'm going to go hypo in the night. You know, all of those things, you know, I don't, you know, and it's not just me, but the people that you know, my husband doesn't have to worry that he is going to be woken in the middle of the night, you know, and needing to call ambulances and things like that, which was happening. So this is just unbelievable for people with type 1 diabetes. So, you know, and I'm so grateful for NHS England, really, that have been managing to put this through. So if anybody that doesn't know what a hybrid closed loop pump is, it is basically an insulin pump that connects to a continuous glucose monitor, and in the middle of that is an algorithm, and it's a program that calculates, works out what the blood glucose level is doing, the glucose level, it's doing from the continuous glucose monitor, and it tells the pump how much insulin to give. So it lowers, stops, increases, boluses insulin depending what people's glucose levels are. So again, by the time somebody maybe gets an alarm to say your glucose is high or your glucose is low, the pump has already responded to that and is already doing everything potentially that needs to happen. So again, it's reducing this burden of diabetes, and you know, we know that having a long-term condition like diabetes can be an incredibly burdensome thing to live with from a mental health point of view. So it is amazing, and you know, as you can probably see, I'm wearing an insulin pump. I'm also wearing a continuous glucose monitor. You wouldn't necessarily know that I have diabetes unless you sat next to me and you're hearing my pump alarming like it was earlier. So the other thing that we know about now is that unfortunately people are getting diabetes earlier, so they're going to be living with it for a much longer length of time, and sadly I do a transition clinic and work with the paediatric team, and my paediatric team have seen a 300% increase in young people with diabetes, and that's in the paediatric service. So that is, you know, people under the age of 16 getting diabetes, and that's, you know, really, really sad that those young people are going to be living with diabetes for a much longer period of time than we have ever seen, really. So it's more likely to happen in women, in ethnic minorities, and obviously those people living in deprived areas. And as we've heard this morning, those people are more likely to have long-term conditions, multiple long-term conditions, and that is having an impact on health. So, you know, and the other thing that, you know, I do antenatal clinics and things like that. So if it's women, these women are going to be coming through with type 2 diabetes, and then pregnancy on top of that. You know, it's a much higher risk pregnancy. So, you know, we have to be aware. And also, they're less likely to achieve the targets that we would want them to achieve. So better HbA1cs, and also about, you know, attending reviews, and you know, and we know that we don't get all of the 8 care processes in most areas that, you know, that we still need to be encouraging people to go and get all of their tests done. So there is a programme that has been introduced called the Today programme, and it's again really about looking at not just looking at diabetes management. It's about weight management, it's about lifestyle choices, it's about psychological support, and we're all probably lacking in that area, unfortunately, of getting that psychological support. We all struggle. I think we know that there's not a huge amount of psychologists out there, and there's even less that are diabetes specific. So we do struggle to get that support for our patients. And there's a much higher risk of having a mental health condition when you have diabetes. So, it is a really important factor, and it is something that we really need to be looking at. But the Today programme is there to try and help and support people under the age of 39 who are diagnosed with diabetes. So it is the adult population, really, and, paediatrics are another service that do need to be looking at support with regards to management of the young with diabetes. Okay, I will hand over.
Thank you, Tamsin. So our next speaker is Professor Helen Hurst, who has worked in renal medicine for over 30 years, including 16 years as an advanced nurse practitioner, and today she's a professor of nursing at the University of Salford and a consultant nurse in renal medicine, and is an executive and co-founder of AN UK.
Thank you very much. So I just want to do a little check. Hands up, anybody from the kidney world? Whoa! Yay, we're not the poor relations, as we were mentioned this morning. So I'm just going to do just a few slides, just a little kind of whistle-stop tour of where we're at in the world of kidneys. So yes, this is me, Helen, and I'm the co-founder of the Association of Nephrology Nurses UK. Those are my disclosures. So, this morning it's the poor relation, and I think there's been probably a lot of policies and public awareness being come to the front really about kidney disease. So this is, I'm trying to look where I can look. So this is a report from Kidney Research UK, and it's kind of, a health emergency, and I think it doesn't matter any of the conditions we've talked about this morning. I mean, thinking of a health emergency is quite wow. And there are some facts and figures in there, and I'm just going to go through some of them in more detail. But this report was looked at very much from a health economic perspective. So the cost of us not doing something about early detection of CKD, the cost to the health service and the cost to individuals. So it was quite a hard-hitting report, and they've taken it to Parliament. And we've got a new Parliament, everybody. We've not mentioned it yet this morning, but hey, I'm going to mention it. Who knows what's coming in the next months, years, but it's really important. And this is, if we look at the epidemiology, I've got to say a big shout out and thank you to one of our nephrologists who lent me quite a lot of slides for this morning, I have to say. I think as well, just to say from a kidney point of view, what's quite interesting about being here today, a lot of nurses who work in the world of kidneys tend to work with patients much further down the trajectory. So a lot of specialist nurses, I work in advanced CKD and dialysis, not so much in the early CKD, which we've heard a lot about today, and a lot of people who work in diabetes and heart failure, those are the patients that you're seeing. So it's funny for us in the world of kidneys. Should we be out there more in early CKD management? That's another question. But if we look at, some of the facts and figures, we know, as has already been said about the hidden thousands of people with diabetes, we have the same problem with CKD. It's a hidden problem that we're not picking up early enough. And, the outcomes and the consequences for individuals are quite huge. So mortality, cardiovascular disease, unplanned admissions, and, acute kidney injury is also a big problem. So when people have got underlying CKD we don't know about, then they are much higher risk of acute kidney injury. And everybody, all those people with all these multiple long-term conditions are at risk of acute kidney injury. And certainly, I don't know, is there anybody who specifically works in AKI? Because we have a lot of AKI nurse specialists. No, okay. And so every year, from our point of view, when I'm talking about the impact of what we're seeing with people with end-stage kidney disease and advanced kidney disease, is more and more people needing to start renal replacement therapy, okay? And yes, transplant is the gold standard. We aim to preemptively transplant those individuals, but not everybody can have a kidney transplant or is, fits the criteria. And with a growing older population, then we are seeing more people coming to us that require renal replacement therapy or conservative management. We do manage a lot of people conservatively who don't have active dialysis treatment. And I would say in the last 2 years, we've seen an enormous challenge in terms of dialysis capacity. This is data from the Renal Registry. It's always a little bit old. We've got up-to-date data. There's a team over there that I work with in the Northwest Network. We've been looking in detail about dialysis capacity. This is a national problem. We have not had enough dialysis capacity, and that's because there's been a surge in the last 1 to 2 years. Many reasons for that. COVID is a big reason. There was lots of people hidden out there that we didn't know were there and didn't know were coming our way. And, there are many reasons behind that. So there's a lot of work looking at dialysis capacity because it's a big problem. We've just not had enough. We're hoping that we can swing it the other way, but, it's been a huge national crisis, really. But that prevalence is going up, as you can see, and that older population. Lots of guidelines and recommendations. KDIGO was mentioned this morning. KDIGO is an international global outcomes group that looks at guidelines. We have our own UKKA, UK Kidney Association, produces guidelines, the technology appraisals. I wouldn't say that there has been, the KDIGO have had a few new guidelines out in the last 12 months. But we are driven, and we've talked about guidelines and the overlap, and we do produce our own, very much so in the kidney world. But I think we've covered that pretty much this morning in how we should be aligning them better across the different diseases. We were asked to sort of talk about the challenges. God, we could talk about challenges, couldn't we, for specialist nursing all day, really. I just wanted to make the point that the role of specialist kidney nurses is quite vast. So we have specialist nurses, advanced nurses, I'm a consultant nurse, tend to sort of specialise in speciality. So we have CKD nurses, perhaps that work more with advanced CKD patients around the education. We have specialist nurses who just do transplantation. So we have lots of subsets of specialist nurses across the service. One of the big things that I'm quite passionate about is education of nurses. We are looking really closely at, trying to develop some national competencies. We've lost that standardisation. I have been in renal nursing for more than 30 years, much longer. Back when I was an early renal nurse, it was it's recognised that you needed to have a renal course and that you wouldn't progress professionally without demonstrating that, postgraduate, I suppose, qualification. We've lost that because many courses disappeared. We lost EMB, they went to the universities. So we've lost that kind of standard structure. We're trying to get that back. If you look at intensive care and critical care, they've got a really nice framework, and that's something that we want to bring into the world of kidney nurses, really, and get a career framework. Which is really, I just wanted to just mention what's been happening now in the UK. So this was a big piece of work that I started a number of years ago, but we launched it last year. So we've managed to get an online course. It's not accredited with the university, but we wanted to get something that was a standard that we could get all kidney nurses access to. It took a long time to get there, and it's not finished yet. We need to continue this journey. But it's going really well. We're getting units and trust to bulk buy it so that we can get as many nurses accessing it as possible. And this is, and UK, we've got communities of practice to try and support those nurses within those specialties. So that's all I want to say about State of the Nation. And I'm going to hand over to the next person. Thank you.
Thank you, Helen. So I'm going to introduce myself. So I did introduce myself at the beginning. So I just wanted to say that from a heart failure point of view, I took the scenic route. So I'm a generalist by background. I've never worked in a cardiology ward. I've worked in the acute setting, intentionally moved around throughout my career, ED, ITU, MEU and things like that. Worked in primary care then for 12 years where we'd set up a chronic condition service. And then that developed into an acute response service, and then in 2018 supported heart failure clinics, 2013. So I did heart failure clinics for 5 years in the community, and then in 2018, with the support of pharmaceutical industry funding, I moved into the acute setting and set up an acute heart failure service in Morrison Hospital in Swansea. So all of that experience, having not worked in a cardiology ward, but having a generalist background, has really helped me to not have tunnel vision, because patients have of course got more than one comorbidity, and having that experience really helped me. So you can take the scenic route, and it does work. So moving on to the presentation. So these are mine and Becky's disclosures. So over 1 million people in the UK have got heart failure that we know about, and 200,000 patients are newly diagnosed every year. But a staggering 80% of those are diagnosed in hospital, despite the fact that 40% of those would have developed symptoms potentially months before coming into hospital. Now we know that when they come into hospital, there are poorer outcomes with mortality, 10%, and multiple problems, hospital-acquired infections. So we're missing these patients. They're being diagnosed in hospital, not in primary care. And they account for 5% of emergency hospital admissions, 2% of the entire NHS budget, and a significant amount of money worldwide is spent on heart failure. And the rates are set to double by 2040. And that's not just because of the ageing population, but because of the big baby boom that we had, that these patients, by then, in the 70s, 80s, are going to be heading into hospital if we don't do something now. So this has been touched upon before in previous talks, but people with heart failure have got generally one or more comorbidities, and they're living with other long-term conditions such as kidney disease, diabetes, or obesity, and they're all interlinked. Really, you can see there that up to 40% of patients who have heart failure have got diabetes, 50% have got heart failure, have got CKD. And that these are increasing, that 60% of patients with heart failure have both diabetes and CKD, and the combination of these three comorbidities are associated with substantial increase in risk of hospitalization and mortality. And you can see in a new onset heart failure, hospitalizations and deaths are highest in patients with type 2 diabetes and CKD, and with both they're worse. The prevalence of heart failure in diabetic patients is 4 times more than that of the general population, and diabetes and heart failure independently increase the risk of one another. So I'm not going to talk about the different heart failure types, but I just wanted to show you that there are different types of heart failure: reduced ejection fraction, otherwise known as left ventricular systolic dysfunction, very often the dilated cardiomyopathies. Becky's going to go into a little bit more detail in the deep dive session on these, but I just want to show you the differences. We've got diastolic heart failure, preserved ejection fraction, other myopathies, right heart failure, valve disease, and so on. And just to make a note, really, the heart failure with preserved ejection fraction, a lot of heart failure services within the UK don't see HFpEF, as we call it. Now, these patients are in and out of hospital all the time, but there's no funding in a lot of areas, so very few services provide that. And we need to change that because these patients are in and out all the time in hospital. So I just wanted to show you a little bit on the left there. This is from the NICO heart failure audit, the percentage of echocardiography's findings in patients with heart failure. So most of them will have left ventricular systolic dysfunction, but you can see that valvular and diastolic dysfunction are quite high in numbers as well. So LVSD is the most common, but there are a lot more out there of different types of heart failure that require different treatments. And interestingly, these are the links with what we call hFrEF and hFpEF and other conditions. So a lot of more patients who have got hypertension, AF, diabetes, valvular disease will have non-hFrEF. So in other words, the hFpEF patients, the diastolic heart failures, will have these other more comorbidities more so than the hFrEF patients. So this is the current heart failure guidance that we follow. You've got the 2021 ESE guidance. It's about 80 pages, something like that. It sounds a lot, but it's broken down into chapters, and it's a really good read. You can take snippets of it so if you want to learn things. And the focus report then with some updates in 2023. Got the acute heart failure diagnosis and management and the chronic heart failure diagnosis and management. So the chronic heart failure diagnosis and management is currently being updated with NICE from a pharmacology perspective. I just wanted to bring your attention to a couple of these. So in the acute heart failure diagnosis and management, there should be specialist teams within the hospital setting. Now, how many of you work in the hospital setting and have got a specialist heart failure team? Okay, that's actually quite good. But more often than not, what you'll find that a lot of hospitals within the UK who don't have specialist heart failure services within the hospital. And the NICE guidance says for a long time now that you should have a specialist input because a lot of mortality rates and the drugs that they're on, I'll go through that in a little bit more detail later on, highly dependent upon whether they've had specialist input or not. And then a follow-up clinical assessment on discharge should be within 2 weeks of being discharged from hospital. How many of you get access to that 2-week post-discharge review? Very few. And so there are high risk of readmissions within 30 days of discharge. And so that is so important, but yet we're not able to deliver that. So the chronic heart failure guidance says that you should have an MDT team working in collaboration with a lead physician, specialist heart failure nurse, and a pharmacist, and that having that in place will help to prevent admission to hospital. So it's so important, though, that service is responsive. So when a referral comes in, that the specialist heart failure service is able to see that patient within a reasonable time. Now, in our health board, that turned out to be, for a rapid access diagnostic clinic, consultant clinic, then it was 106 days pre-COVID. So what we were seeing in the hospital was referred by GP to a heart failure service 2 months ago, 1 month ago. So it wasn't responsive. And if you haven't got that, you can't work one without the other. So you've got to work together. So we had to do a whole service development, look at the resources, put business case in to get more resources. One was my role, actually. I was 4 years seconded. The hospital didn't actually employ a heart failure nurse. I was on secondment, so we had to put a business case in for permanent positions and things. And eventually we're in a place now where we can offer that 2 to 3 week review. And what we're not seeing in hospital is those patients that were referred a month ago, 2 months ago. So what are our challenges? So the last audit that we did, you should have 1 whole-time equivalent heart failure nurse for 100,000 population. That's what was being provided. But we're now in a place where we actually, the GIRF report and a paper that was done by Jane Masters and et al. In 2019, we should have 2 to 4 per 100,000 population. And that, of course, then would include seeing the hFpEF patients, which we're not seeing at the moment. There is increasing prevalence. They're very complex with multiple comorbidities, as we know, and we've got overstretched services. We're not all providing responsive service, and there are inequities in service provision across the UK. Just to give you a little example, you've got a rapid access diagnostic clinic in one area being provided by a heart failure consultant, in another area you've got it being provided by a band 7 nurse, in another area you've got it being provided by a nurse consultant. So there's inequities in service provision and delivery. You might have a heart failure services who have got enough nurses in this one, and maybe 1 or 2 nurses in this one that not been able to deliver. So it's different everywhere, and different banding and different roles. So we really are looking at working on that. in the inpatient and in the community setting. So we've got the BSH Nurse Forum competency document. We've got there are some heart failure specific models in the UK. We are looking at developing more, but you need access and time for funding like anywhere else. So these are the challenges that we're facing at the moment. Thank you.